Hey there, I am podcasting an anatomy review for the hip, knee, and ankle. So this week we're going to go over all lower extremity, and instead of making 3 separate podcasts for the anatomy, I'm going to go over all of the anatomy in one podcast. Alright, we're going to start with the pelvis and hip region. So the structure of the pelvis and the femur are designed to help distribute weight and forces from the ground up through the body. So the pelvis, you have a right and left innominate. So this here would be the right innominate, and over here is the left innominate. They are joined at the symphysis pubis, so right here in the center, and they also have attachments onto the sacrum. The femur comes in and joins at the pelvis at the acetabulum, and the angle of the hip is approximately 125 degrees, and this helps to both distribute forces and to attenuate some forces. Right, the hip joint is a ball and socket joint. So the pelvis is the concave, the femur is convex. You have 3 main ligaments that control motion at the hip. They're easy to remember based on their name. One is the pubofemoral ligament. It goes from the pubic bone to the femur. The iliofemoral ligament and the ischiofemoral ligament. The ischiofemoral ligament is located posteriorly, which makes sense if you think of where the ischium is and compared to the hip joints. The other 2 joints are more anteriorly, with that iliofemoral ligament being a superior ligament. Right, movements at the hip. So there's a difference between open and closed kinetic chain movement. One would be the femur moving on the pelvis, which would be more of an open kinetic chain. The other is more of the pelvis moving onto the femur as a closed kinetic chain. So let's start talking about the femoral head moving on the femur. So with hip flexion, the articulating surface is going to slide posteriorly. With extension, it will slide anteriorly. And so that's why the extension, when you're limited in extension, you want to do an anterior mobilization. When you're limited in hip flexion, you want to do a posterior hip mobilization. The more you flex your hip, the more the interior joint capsule also gets stretched. So an inferior joint mobilization would also be appropriate. But realize often the leg is stationary and the pelvis is moving on the leg. So if you're standing and you do an anterior pelvic tilt, you're actually causing flexion at that hip joint. And if the body stays upright, you're causing extension at the lumbar spine. The opposite would occur. So if you're standing, you do a posterior pelvic tilt, the movement at the hip joint is into extension, and the movement at the lumbar spine is to decrease that lumbar lordosis. This also occurs with AB and adduction. So if you're standing and lift your leg up, so you become non-weight bearing on the leg you're moving, and you adduct your leg, that is the movement that occurs at the hip. But if you're standing, let's say you're standing on the right side, and the left side of the pelvis drops down, you will also be adducting on that right side. All right, and now to the knee anatomy. With the knee, there's 2 distinct joints, the tibiofemoral joint and the patellofemoral joint. So let's first talk about the tibiofemoral joint. This is obviously the joint, the articulation between the tibia and the femur. The femoral condyle, the 2 condyles are not symmetrical. So the medial condyle is longer and has a larger surface than the lateral condyle. And this contributes to that locking home mechanism, or that little bit of rotation that occurs at the end of knee extension, or if the knee is extended as it starts to move from knee extension. And you also have 2 meniscus on each condyle. They're attached to the tibia, and they help with some congruency of the joint and of the articulating surfaces. So you also have the patellofemoral joint. Now the purpose of the patella is to increase that moment arm to allow the quadriceps to have more efficiency when they work. It is a sesamoid bone, so it is not attached to any specific joint, or any specific bone I should say. It does float within the quadricep tendon. The undersurface, so the surface that does articulate with the femoral bone, with the femur, is made of smooth hyaline cartilage. This next slide is just a review. You should know these from anatomy, but the main ligaments of the knee, you have your medial and lateral collateral ligaments. Lateral collateral does go down and attach to the fibula. You have your anterior and posterior cruciate ligaments, which limit anterior and posterior translation of the tibia on the femur, or in a closed chain of the femur on the tibia. Alright, again, the function of this patella is to increase the moment arm of the quadricep muscles. So it improves its ability to function to increase knee extension motion. The cartilaginous undersurface, its goal is to reduce the friction as that patella slides up and down on the femur. So there's a lot of forces that go into play related to the alignment of the patella. One of the forces is the Q angle. You learn to measure Q angle in tests and measures, and it's the angle formed by the intersecting lines from the ASIS, or the anterior superior iliac spine, to the mid-patella, and then from that mid-patella down to the mid-surface of the tibia. Women tend to have higher Q angles than men, usually 10 to 15 degrees or so, but a higher Q angle suggests there may be more lateral pull to that patella. A true structural Q angle, so somebody that has a little bit of increase in valgus compared to someone else, isn't something that we can change, but we can change the amount of forces and the direction of forces put on that patella through muscle activity. So what are those muscles that we can control? So we have your vastus medialis and vastus lateralis that can provide some stability medial lateral over that patella. You also have some attachments to that extensor retinaculum from the IT band, from the medial and lateral patellar ligaments, which wouldn't be dynamic, but those are some static constraints to patellar movement. Additionally, if you think further distally, if you have tight plantar flexors, so your gastroc or your soleus are tight, and we'll talk about this a little bit more in foot function in a few minutes, but if the ankle is dorsiflexing and your plantar flexors are tight, it does cause a rotation of the tibia. So this rotation laterally would put the attachment of the patellar tendon more laterally, which may increase that Q angle. So a lot of patellofemoral problems may be related more proximally to things such as the IT band, or the ability to control femoral motion, or it could be more distally at the foot. In someone that has weak hip abductors or weak external rotators, as they bend their knee, they may move into adduction, which would increase the valgus and also cause an increase in that patellofemoral lateral pull. So as someone bends or straightens their knee, there's different parts of the patella that come into contact with the femur. So when the knee is in complete extension, the patella is actually superior to that trochlear groove, and there's not a whole lot of pressure, if any, of that patellar onto the femur. But as you start to flex the knee, at about 15 degrees, you start to get some compression into that trochlear groove of the femur. And as that knee increases and the patella slides distally into the groove, that contact increases. So beyond about 60 degrees, as the knee goes past 90 degrees, the quad tendon actually starts to contact the trochlear groove and the patella slides inferiorly. So there are some compressive forces on that patella. So again, when the knee is in full extension, there's very minimal contact of the patella on that trochlear groove, but as you start to bend, the forces on that patellofemoral joint increase. Fortunately, you also have an increase in the amount of surface area that is touching between the femur and the patella. In squatting, so in a closed chain activity, that patellofemoral force increases until about 90 degrees, and then it starts to decrease as the quadricep tendon is what is contacting the trochlear groove. Now, if you put a weight on the distal end of your leg, so put a weight around your ankle and do an open kinetic chain knee extension, the greatest joint reaction force is around 30 degrees from full extension. So the amount of patellofemoral force you have varies depending on whether it's an open or closed kinetic chain. Additionally, if you have an increased Q angle or you have increased valgus in your knee, or there is some reason to note that there's a more lateral pull of that Q angle, you'll have an increase in your lateral facet compression at the knee. And again, the location of where the stress is on that patellofemoral joint changes as the motion changes. So initially at 0 degrees, there's no pressure. Once you get to about 15 to 20 degrees, it is at the inferior pole of the knee. That pressure moves to the middle of the patella, and then at about 90 degrees, it is more in the proximal part of the patella. You have decreased pressure until about 135 degrees, and then you will get pressure at the odd facets or on the lateral aspect of the patella. All right, let's move down to the ankle and foot. So, right, the lower leg is made up of two bones, the tibia and the fibula, and these are bound together by a membrane to help create a strong capsule that encloses both the proximal and encloses the proximal tibiofibular articulation. So unlike in the arm where the ulna and radius, the ulna will rotate around the radius. I said that backwards. The radius will rotate around the ulna. The tibia and fibula do not rotate around each other. There is slight movement, but overall, too much motion in this joint is pathological. So when we talk about the foot, we break the foot up into three sections: the hind foot, the midfoot, and the forefoot. The hind foot consists of the talus and calcaneal, and this is the posterior foot segment. Think of this as kind of your heel area. The midfoot is the navicular, the cuboid, your three cuneiforms, and then the forefoot are your metatarsals and your toes, your phalanges. All right, so let's talk a little bit more about the tibiofibular joint. So the superior tibiofibular joint is up around the knee. It is near the knee joint, but it is not included in its own in the capsule with the knee. The proximal tibiofibular joint has its own capsule, and which is reinforced by an anterior and posterior tibiofibular ligament. The inferior tibiofibular ligament is around the ankle. It has a very strong articulation, and it is supported by the tibiofibular interosseous ligament and the anterior and posterior tibiofibular ligaments. So the movement, we don't often talk about tibiofibular movement. It's not something that we can measure, but we do expect some tibiofibular joint movement and elasticity, especially with ankle range of motion. If there is not some accessory motion in the tibiofibular joint, you'll be limited with ankle dorsiflexion range of motion. All right, now we're going to talk about the hind foot, or the ankle talocrural joint. So this is the joint between the talus, the tibia, and the fibula. It's supported medially and laterally by the malleoli. It also has a capsule, but it is a fairly thin and weak capsule. There are also ligaments that help support it. So medially it is the medial collateral ligament or the deltoid ligament, depending on what you call it. And laterally there are several lateral collateral ligaments, the anterior and posterior talofibular ligament and the calcaneofibular ligament, that help maintain stability. Because the fibula extends further down than the tibia, the mortise, the joint is angled slightly outward and downward. So the surface of the talus is a concave, where the tibia and fibular joint is considered convex. All right, so what movements occur here? So there are multiple planes of movements that can occur. So in the sagittal plane, it is dorsiflexion and plantar flexions. In the frontal plane, it would be an inversion or an inward turning of the joint, and eversion. Within the transverse plane, there is abduction or movement away from midline and adduction. But often these occur in often movement at the ankle occurs in multiple planes. So pronation is a movement that is a combination of dorsiflexion, eversion, and abduction of the ankle, or of the talocrural joint. So during weight bearing, pronation of the subtalar joint causes the arch to lower, which is a relative supination of the forefoot with some dorsiflexion of the first metatarsal. So open kinetic chain supination, though, is a combination of plantar flexion, inversion, and adduction. So in the lower extremity, there is always a relationship between what happens at the hip, the knee, and the foot, especially in a closed kinetic chain environment. So we're going to talk a little bit about those relationships now. So if you are in a weight-bearing position and you have hip flexion, you will also have knee flexion and ankle dorsiflexion if your body stays upright. And the opposite occurs if you have hip extension in weight bearing. That also causes your knees to extend by pulling your femur posteriorly. It also helps contribute to that locking mechanism of the knee. And you will have some ankle plantar flexion. So you'll go from a dorsiflexed position probably to neutral, but you're moving into some plantar flexion with that. So if you're standing in single leg stance or unilaterally, gravity causes an adductor moment at the hip. So if I'm standing on the right leg, we talked about this a little bit earlier, the left side of my pelvis wants to drop because gravity wants to pull it down. This causes a relative adduction at my hip. This actually results in a varus movement at the knee. I apologize. So it can cause a valgus movement at the knee. But if you have strong glute medials, they will pull and maintain your pelvis in a upright position and maintain the femur in a correct posture, so you don't get that increase in valgus. So realize decreased flexibility at the hip or the knee or the ankle will have implications throughout the chain. Also, muscle weakness will also cause some imbalances and cause abnormal movement at other joints. Right, at the knee, you have muscle function in both open and closed chain. So let's talk about the closed chain muscle function. So the quadricep muscle controls how much knee flexion occurs by extending the knee when it contracts. The patella does provide a mechanical advantage. We talked about that with the patellar function earlier, with the greatest effect being at about 60 degrees of knee extension. But realize that that effect diminishes at near full extension. So after you get to about 15 degrees, if you're going from bent to straight, and you get to about 15 degrees, you no longer have that mechanical advantage of the patella in the knee. And so in a closed chain, as the muscle is shortening, so as you're going towards full extension and you no longer have that mechanical advantage, realize other joints may kick in to assist. So if you are going from a squat to a stand and you are extending at the knee, your hamstring and glute muscles can assist by at the hip, by extending at the hip to cause some knee extension. So even though the knee flexors may be working in a closed chain, they may be working more at the hip than at the knee to help extend when you're going from a squatted position to a standing position. So dynamic stability of the knee. Realize that it is a concave on convex in an open kinetic chain, but the stability of the knee is not provided by those two surfaces. It doesn't have enough bony congruency to provide a whole lot of stability. So the ligamentous stability is one of the things that is relied on, but you can tell from the frequency of ligamentous tears that often is not the system we want to rely on. Having good dynamic stability of the knee or good neuromuscular control is necessary to help with limiting falls, help with decreasing the amount of tears you have, especially tears of the ACL. All right, and what about the ankle and the foot? How can that affect motion elsewhere? So if you have supination of your subtalar joint, you get some lateral rotation of the tibia. And conversely, with pronation, you get a medial rotation of the tibia. Also with supination, you have an increase in your longitudinal and transverse arches, and with pronation, you have a decrease. So in standing, if you have one leg that's more supinated and the other is more pronated, you may have what appears to be a short leg on one side, or the body may be compensating and pronating and supinating if you have a structural leg length difference and your body is trying to sort it out and maintain a neutral pelvis. So abnormal foot postures can occur from the hind foot, the midfoot, and the forefoot. So if you have a significantly pronated foot, that can come from a varus deformity of the calcaneus. It can come from a loss of the longitudinal arch. It can also come from some valgus at the knee. So again, looking at foot postures is important, but being able to relate it to knee and hip function is also necessary. There should be an easy review of the muscles in the ankle and foot. Your primary plantar flexors are the gastroc and soleus, but you also have muscles that help with plantar flexion, like the tibialis posterior, the flexor hallucis longus, and the flexor digitorum longus. And the dorsiflexors are the anterior tibialis muscle, the extensor hallucis longus, and the extensor digitorum longus. In these next three slides, I'm going to talk about what muscles are involved with walking. Now, this is a very superficial view. We'll have an entire class on looking at this deeper, but I do want you to have a basic understanding now so that we can talk about this. So let's talk about the hip. So when you're walking, your hip flexors initially contract to initiate that swing. So the leg that's in the air, it helps to move it forward. If you have tight hip flexors, you can't get that leg completely behind you, so you may have a short step. Your hip extensors, so your glutes and the big muscles on the back, they help with loading response. That's when you first touch your foot to the ground and put weight on it. Your gluteus maximus helps to work to cause hip extension to keep you from falling down. Also, the glute max helps to propel you forward by pushing that femur backwards. Right, your hip abductors, they work to control your lateral pelvic tilt. So when you have loss of gluteus medius function, your trunk may shift to provide more of a mechanical advantage over that, or the other side of the pelvis may fall. Also realize that other musculoskeletal impairments such as pain may cause some problems with the gait pattern. So just because someone's limping doesn't mean they necessarily have a weak or a tight muscle. They may just hurt. Alright, so muscles of the knee during gait. So the quadricep muscle helps to control the amount of flexion during that initial contact and when you put weight on that leg initially. So again, the glutes are going to work to extend the femur at the hip. Your quads will work to extend the knee. The main function of the hamstrings is to decelerate. So as you're swinging and you kick that leg out in front of you before you touch it to the ground, there's a lot of momentum going. And if your hamstrings don't eccentrically control that, your lower leg's just going to snap out there and go too far. So that is one of the main points of the hamstring. It works eccentrically during that swing phase. Also, it does provide some support to the posterior aspect of the knee when you're extending, so that you don't extend too far and hyperextend your knee. The soleus and the gastroc, while their main function is at the ankle, they do control movement of the knee by controlling the movement of the tibia when the foot is on the ground. And so if your foot's on the ground and you're moving and say your leg is trying to bend is because gravity is pulling you down, as long as your foot's on the ground and your gastroc and soleus are working, it will pull that tibia posteriorly to help extend the knee. Alright, so things that are working at the ankle during gait. So first you have your ankle dorsiflexors. These have to work to be able, during that swing phase, so that your toe doesn't get caught on the ground, so you don't get a toe drag. Your ankle plantar flexors, back to dorsiflexors. Also, when you put your foot on the ground initially, if your dorsiflexors don't eccentrically lower your toes to the ground, you'll end up slapping your foot on the ground. Plantar flexors, those help to propel you at the end of gait, so right when you're pushing that leg off in the back. It also, as we talked about, it helps to control that tibia so that it doesn't bend at the knee. Your ankle everters and inverters control how much pronation and supination you have. So as you put weight on your leg, your foot is going to pronate some. That helps you to absorb some of the weight. But as you go to push off, you want your foot supinated again because it creates a stronger force. When you're pronated, all your bones are not in it; they're in the open pack position. And when you're supinated, it creates a stronger foot to push off of. And so the ankle inverters and everters are going to make sure that your foot is in the proper location to provide either the most weight acceptance or to provide the most force. And then your intrinsic muscles help support the transverse and longitudinal arch. Alright, so now we're going to talk about nerve injuries. I'm going to talk about hip, knee, and ankle nerve injuries. So at the hip, there's three major nerves that are subject to entrapment: the sciatic, the obturator, and the femoral nerve. So that sciatic nerve can be impinged anywhere from where it exits and forms outside of your lumbar plexus all the way down to the muscles it innervates. It can occur as it passes deep to the piriformis muscle, because sometimes it occasionally passes over or through that piriformis, and you can get entrapment there. The obturator nerve, an isolated injury to this is rare, but it does, because of its location, can be injured when a woman's giving childbirth and the fetal head pressure during labor is prolonged, or if the doctors have to use forceps to deliver the baby. The femoral nerve, typical injuries occur with fractures of the upper femur or of the pelvis. If you have if they have to reduce a dislocation of the hip, or again, if there's pressure from forceps during childbirth. Also at the hip, you can get referred pain, so it doesn't have to be necessarily the nerve that is damaged. So there are some referred pain patterns of the hip from the facet and from lumbar spine, and these are very common nerve root referral patterns, or I'm sorry, not nerve root, but lumbar facet referral patterns. So at the knee, nerve injuries that occur the common fibular nerve and the saphenous nerve. So the common fibular nerve is very superficial, where it winds around the fibula just below the fibular head, and this is a common site of injury. If someone has a lateral injury where they break their fibula right there at the knee, you can get sensory loss and muscle weakness distal to that site. The saphenous nerve may be injured with any trauma to the region of the nerve. And here is a diagram of the saphenous nerve and its location. Alright, nerve injuries of the ankle. Some of these are continuations of the injuries that can occur at the knee, such as the common peroneal nerve. You also have the posterior tibial nerve, which gets entrapped in the tarsal tunnel, and the plantar and calcaneal nerves. Now these pass over the medial aspect of the foot through the openings in the abductor hallucis muscle. Overpronation can occur, can cause some nerve damage to the plantar and calcaneal nerves. And here's a picture of all the nerves and the innervations of the lower leg, the cutaneous innervation. So realize that knowing your anatomy, remembering what nerves innervate what area, will help you to be able to determine the cause of the problem. And also the problem can be coming from a nerve root. So we talked about looking up the chain. Just because the problem's in the foot doesn't mean it's not coming from the knee or hip. It could be coming from the lumbar spine. So knowing your nerve roots and the segmental sensory innervations of the foot will help to determine where the cause may be coming from. Thank you.